lymphedema, atelectasis. So the classic is COPD. And that's how you kind of remember what respiratory acidosis, the picture of respiratory acidosis looks like. So what does their breathing look like? It's shallow and rapid. Shallow and rapid, so they're hypoventilating, right? Hypoventilating. So what is their CO2 level going to be? High. Their CO2 level is high. So if we remember our Rome, we remember that respiratory is always opposite the pH, right? Purple markers. Okay, so with respiratory acidosis, the pH level is going to be low because it's acidotic, right? And the CO2 level is going to be high. Now, what is going to try to be compensating here? What's going to kick in? The kidneys are going to kick in, and they're going to try to conserve more bicarbonate because bicarbonate is a base, and it's going to hopefully get it back into a homeostasis situation, right? So, if we want to say that it's compensating, how will we know that it's fully compensated? The pH is going to be normal. Okay, if it's partially compensating, it's better. It's not totally back to normal, but we see improvement from the first ABG that they drew, right? Okay. All right, so what do we really do for these people? Treat the underlying cause, right? Treat the underlying cause. And remember, we talked about with chronic illnesses like COPD, you can't ever cure them. They're never going to, there are people that live in respiratory acidosis all the time because they're never going to get totally better. They may get some improvement, but they're never going to be cured. But if it's something like pneumonia, we give antibiotics, right? Bronchodilators, stuff to thin the secretions because our biggest thing is to maintain that airway, right? Okay. All right, now, respiratory alkalosis. Okay, what does a respiratory alkalosis patient look like? They're hyperventilating. So some of the causes of that: stress, high altitude, anxiety. There was a medication that we talked about. Salicylate intoxication. Okay. All right. So their pH is what? High. And then their CO2 level is low because they are breathing off the CO2, right? Okay. So it's an increased loss of CO2 from the lungs. So how do we know that they are conserving, or how compensating? The pH is going to be getting back to normal, but what is it that's the bicarb again is going to be doing what?
Your kidneys are going to be getting rid of more bicarb.
Okay, the kidneys are going to be getting rid of more bicarb. Okay, because we want more hydrogen ions, right? Okay. Okay. They're at risk for seizures. They have deep, rapid breathing as opposed to shallow, rapid breathing. So they're hyperventilating. We talked about the paper bag trick, right? Because if you make a good seal with a bag, they're going to suck in more CO2. They're going to retain more CO2 instead of blowing it off. They are going to complain of numbness and tingling in their extremities, around their mouth. They're at risk for seizures. Okay. All right. Metabolic. So now we're going to talk about the metabolic side. Now, the substance that we were looking for here was CO2. Okay? Because that's a respiratory marker. In this case, we're going to be looking at the bicarb levels. We're going to be comparing bicarb levels. That's how you know that it's metabolic in nature. Let's look at the bicarb levels. So, in metabolic acidosis, okay, one of the classic cases of metabolic acidosis is diabetic ketoacidosis. And that should make sense because it has acidosis in it. Okay? The diabetic ketoacidosis. There are some other causes as well. Severe diarrhea. I don't mean just a one-day bout of diarrhea. I mean over a long period of time. It usually is accompanied by other things like starvation, malnutrition. So who would have chronic diarrhea? Who would be Crohn's disease, IBS, Shigella, chemo patients? Okay. Okay. Other things that may cause it: renal failure. Exercising, yep, holding on to too much lactic acid in the muscles. Yep, increased exercise. Severe infection can cause it. Okay, so the picture of somebody in acidosis, metabolic acidosis, is headache. They're going to be hypertensive. Hyperkalemia. Do you remember we saw that before, didn't we? With our respiratory acidosis. Remember that? Okay. Hyperkalemia. Muscle twitching. Muscle twitching. They're warm, flushed skin. They're going to feel very hot to the touch. This is something important that I don't know that you've heard before. This is poo-small respirations. Have you ever heard that term? Poo-small respirations. It goes along with diabetics, and what they're doing is they are hyperventilating themselves as a compensatory response. So if we've got we talked about before with our respiratory problems, the buffer was the kidneys, right? Now our problem is the kidneys or the metabolic system. So what's our buffer going to be here? The lungs, respiratory. Okay, respiratory. Okay, so they are going to be hyperventilating those deep, rapid respirations. Deep, rapid respirations. Okay. So, what's our pH going to be? pH is going to be low. Our pH is going to be low. And in this case, remember Rome, respiratory opposite, metabolic equal. In this case, our bicarb is what we're looking at. Okay, so if the pH is low, what is the bicarb going to be? Low. Okay? Because remember, it follows the same as the pH. Okay? Now, metabolic alkalosis, the pH is going to be high. We're going to talk about that in just a second. And bicarb is going to be high. Okay? All right. So the CO2 is going to be going. How are we going to know that? What's the CO2 going to look like? It's going to compensate. It's going to be high. Okay, it's going to be high. No.
Oh, it's going to hyperventilate, so it'll be low.
It's going to be low. Right, it's going to be low. I'm starting to come out of my cold fog here. Remember, respiratory is opposite. So if it is trying to compensate, it's going to decrease, right? They're hyperventilating. Okay. Yes, ma'am.
pH is low, bicarb's low, and CO2 is low.
High, high,
CO2 is high.
yeah. It's gonna be going the opposite way. Well, it's gonna be low, no. Y'all are confusing me now. It's gonna be low, it's gonna decrease as it's trying to compensate. They're all the same at this point. They're all the same at this point.
This is for acidosis.
Yes.
Oh, gosh.
Y'all are confusing me now. Because if it was up, if the CO2 was up, what would it be? Remember, it's opposite. So CO2, it would be more acidic. Be more acidic. So we want it to be more basic, as it's compensating. Right. Yeah, it's more acidic on here. Down here. Remember, because respiratory is opposite. Respiratory is opposite. All right, I did have an article. I think I put it up for you guys about the Atkins diet. Did y'all see that? What did you think about that? Did anybody read it? Take time to read that. How many of y'all did the Atkins diet when it was real popular? I'll get in a minute. Nobody did it? You had a friend in college that was always on it. Your uncle was always on it. Okay.
And each year he was in keto acid.
Yeah.
Each year he was.
Yeah. There is a fine line. There's a fine line with these diets, and I always try to find stuff that's more, that's stuff that you're going to be interested in, like things like this, that's every day, something that you're going to come in contact with. There is really a fine line walking with some of these diets. And Atkins, actually, there were people who died who did the Atkins diet because they got themselves into an acidotic situation and they couldn't get themselves out of it. You have these signs and symptoms for long enough, you're going to start to have seizures, you're going to get into coma, lethargy. So that's one reason. If you didn't read it yet, I want you to read it because it's a very interesting article. Atkins is not as popular anymore as it used to be. And one of the reasons for that is because of the fact that people were dying. Plus, I think the creator died, didn't he?
In a car accident.
In a car accident. After all that, Sharon Osbourne is doing it, so it's going back. Really be careful when you diet like that because you're going to be creating more problems for yourselves. There is something else I wanted to talk to you about too that's becoming more popular. Erin knows a little bit about this. Children who have chronic seizure disorders that are very difficult to control. There are different types of seizures, but some seizures are very difficult to control with medications. They are putting them on what they call ketogenic diets. And there's a whole big study in Charlotte right now where they're monitoring these children. They're doing ketogenic diets where they are putting them into a state of acidosis and finding that it does, for those children, control their seizure activities because of the fact that it depresses so much stuff. Some children, it makes a world of difference. And in some children, you don't see much difference. So it just depends on the child, but there's a lot of controversy over it. Again, you just have to figure out what's best for you and for your child. But you have to be very, 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 very careful when you get into these acidotic situations that you're not totally damaging your body. So just something to think about. Okay, so some nursing diagnoses, and this is one of the reasons that ketogenic diets or metabolic acidosis is so scary, because it does have that hyperkalemic response. So you have all those cardiac responses, those dysrhythmias that go along with it. Neurologically, they are a little bit more depressed neurologically. They're confused, they're weak, they're drowsy. You have to be very careful about that. Risk for fluid volume deficit if it's diarrhea as a cause. Okay, again, the treatment, just like all those others that we've talked about, is to treat the underlying cause. Whatever the cause is what you're treating. You want to make sure that they are very good and hydrated, so when you're monitoring their INO, you want to make sure that they're outputting as much as they're inputting. Not just fluid though, you've got to make sure that you're also replacing electrolytes. What kind of IV solution?
Normal silence.
Okay, maybe a hypertonic situation. Something though that is alkalotic in nature. So they'll take a hypertonic solution like sodium bicarbonate. That is hypertonic in nature because it's full of sodium bicarb. Bless you. So sodium bicarb they will actually run as an IV. Where do you see sodium bicarb though? Baking soda. It's baking soda. That's what it is. It's essentially baking soda. So sodium bicarbonate is what they're going to administer IV. They also may do sodium lactate if you've got a buildup of lactic acid. Lactate is a base. It's in your water, sodium bicarb. Anybody else have sodium bicarb in their water? Yeah. It's that Nestle Pure Life. Y'all gotta stay away from Nestle.
This is food line.
Does it have sodium bicarb in it?
Yeah.
You got potassium bicarb. Wow. So do we have to be careful? We should be careful with how much water we're drinking that has all that in it, shouldn't we? Tap water is what we be drinking.
That has all kinds of stuff in it.
That's true. That's true. That, I don't think it has sodium bicarb in it.
That has all the other medications people can watch.
Yeah, it does. Okay. All right, so if the cause is, remember one of the classic causes of metabolic acidosis is diabetic ketoacidosis. If it's due to that, you're going to give them normal saline and insulin, regular insulin, normal saline and regular insulin. Patients who are in severe DKA, we get a lot of kids in with DKA, especially this time of the year because they'll get those secondary viruses and it'll cause their blood sugars to go out the roof. They end up in ICU. You never want to give an insulin drip in an unmonitored situation. So you've got to really closely monitor those patients. Those are going to be given in a unit or a telemetry unit, somewhere that they can closely monitor those patients. So insulin as an IV drip. I mean, you may not have ever heard of giving it that way, but it's given as a piggyback instead of given as an IV, a sub-Q injection. Okay. Okay, so you're monitoring their vital signs, their ABG status, especially their respirations and their level of consciousness. Yeah. Any other drug therapy, oral therapy would be aimed at treating the problem. If the cause is diarrhea, chronic severe diarrhea, they're going to want to try to correct that. So a lot of these Crohn's medications may have to be altered. Education is very important on how to prevent this from occurring. So again, you're treating the cause. Okay? All right, so metabolic alkalosis. The opposite. Metabolic alkalosis occurs when you've got severe vomiting or NG tube suctioning. We know that anytime there's a loss of hydrogen ions. So that's when you're vomiting and suctioning, and diuretics is another cause. Excessive bicarb use. These people who take a lot of baking soda. Remember we talked about pica? And that some people with pica eat baking soda. That would cause them to go into metabolic alkalosis. Okay.
Which one is that classic?
This one is the loss of GI fluid, like vomiting or suction. That's when you really see this most. Okay. All right, so you're going to see restlessness followed by lethargy. Again, you've got some neurological signs and symptoms like confusion, dysrhythmias. Now, when we were talking about metabolic acidosis, we talked about Kussmaul's respirations, and they were hyperventilating, right? They were trying to blow off some of that. In this case, it's compensatory hypoventilation. So it's shallow respirations. They're trying to hold on to as many hydrogen ions as they can possibly hold on to. That's how you know. Tremors, muscle cramps, tingling of the fingers and toes. The reason for that is because hypocalcemia goes along with metabolic alkalosis. They go hand in hand a lot. Hypocalcemia. That's what you remember, hypocalcemia, and you have the tingling of the fingers and toes and all that. Muscle cramps. Because what happens is as the pH increases, more calcium is bound, leaving less free calcium in the serum.
Some says cholemia.
Well, there is cholemia too, but I'm talking about calcemia right now. Less free calcium in the serum. You also have hyponatremia. So you got all three: hypokalemia, calcemia, and natremia. And you can figure that out because if you're vomiting a lot, wouldn't you lose a lot of sodium through that vomit as well? Again, it's just like the others. If it's allowed to go on long enough, it's going to cause seizure activities, coma. Okay, so treatment again is aimed at the underlying symptoms. We'll skip through the nursing diagnosis because they're pretty much the same. Okay. In this case, we need to replace all those electrolytes that we lost, right? So, potassium supplements would be important here. Sodium supplements like normal saline, IV normal saline. Now this is going to sound confusing, but I just want you to listen to how I'm saying this. They're also going to give H2 or histamine 2, H2 receptor antagonists. That's like Tagamet. Histamine 2 receptor antagonist. And an example of that is Tagamet. or Zantac. Now, you would think to yourself, well, that reduces acid, and we need more acid in this situation, right? But what that actually does is it reduces the production of that. The medicine, the purpose of it is to reduce the production of hydrogen ions, i.e. acid. If you are continuously producing acid, it's continuously being lost. So you want to stop any acid from being lost, period. So they're going to give it to stop production of acid, to hold on to what it already has. That's why they're giving it, is to help it to hold on to it. Because the more you produce, the more you lose. Okay? And you don't want to lose it. You want to hold on to what you have. So that's why they give it, even though you think of it as an antacid. Okay. Making sure when you're teaching these patients that you're teaching them not to overdo the use of bicarbonate, Tums, anything that has sodium bicarbonate in it. It's a big deal. Okay. All right. Now, that's all of the 4 things. Do you still have? There was one more case study left. Acid base. You saw that? Pull it out, because we're going to do that. While you're doing that, I'm going to go ahead and get the VCR. Some of y'all might be too young to know what a VCR is. Set up, because we're going to do Name the Baby today too, and then tomorrow we're going to practice some more with ABGs. So, okay. So work on this. Everything's better with friends. So just find a friend. Who there?
CO2 is going to be your lungs. Your lungs come before your kidneys if you go from your head to your toe.
Look at you.
So, well, I mean, I didn't do this. I'm just going
The guy from, just the Spanish guy?
No, he's in Spanish or I mean, he perhaps okay.
Yeah, but he, Linares, I think was his last name.
Linares, yes.
Yes, I like him.
It's easier to remember his thing of saying, if you're saying that wrong. Did you want that?
No.
Or 60. Not negative, that's the negative sign.
Okay. I'm gonna watch the other half today. I mean, this is just a simple way. He should.
Arterial blood gas interpretation have the reputation of being complicated and difficult to understand. But we're going to make it simple and fun. You might even enjoy it. ABGs, or arterial blood gases, are one of the most important indicators of a patient's acid-base balance and oxygenation. To be able to interpret blood gases, you must first have a basic understanding of acid-base balance. The hydrogen ion is the building block of the body's acid-base balance. The hydrogen ion controls the acidity of the solution. The pH is the measurement of the concentration of the hydrogen ion in extracellular fluid, in this case, the blood. Because it is a negative logarithm, pH increases or becomes more alkalotic as the hydrogen ion concentration in the blood decreases. Conversely, pH decreases or becomes more acidic as the hydrogen ion concentration increases. The normal pH of blood is 7.35 to 7.45. Any variance from this narrow range results
What do you
in a
think he
patient being
is?
in an uncompensated state.
COPD. And I really want you to pay attention to the
From mild
readout
all the way up to life-threatening
of his
complications.
readout. Look how
A
bad he
patient
is.
with a pH below 7.35 is said to be in a state of acidosis. In contrast, a patient with a pH above 7.45 is said to be in a state of alkalosis. The body, when functioning normally, can maintain a normal blood pH of 7.35 to 7.45 by means of its internal buffer system. The buffer system acts as a defense mechanism that responds to changes in the hydrogen ion concentration so that the blood remains in the normal 7.35 to 7.45 range. The primary buffer system affecting serum pH is the carbonic acid bicarbonate relationship. The free hydrogen ion combines with the bicarbonate to form carbonic acid, which then breaks down into water and carbon dioxide. The water can then be excreted by the kidneys, and the carbon dioxide can be exhaled by the lungs during
Tell this is
respiration.
high tech. They used a
In order
book.
for this buffer system to work, the pulmonary and renal system must be functioning properly. Any disturbance with the lungs or kidneys can upset this delicate balance and result in a state of acidosis or alkalosis. In addition to the pH, other values are utilized in measuring ABGs. These include PCO2, which is the measurement of carbon dioxide in arterial blood, HCO3, which is the bicarbonate in the arterial blood, PO2, which is the measurement of oxygen content in arterial blood, and O2 sat, which is the percentage of hemoglobin saturated with oxygen. The O2 sat is vital in assessing the oxygenation of the tissues. A normal PCO2 is 35 to 45 millimeters of mercury. A PCO2 below 35 is alkalotic, and a PCO2 above 45 is acidotic. Don't get confused. You may think this is backwards, but it's not. An increase in PCO2 leads to an increase in hydrogen ion concentration, which causes the pH to fall. Therefore, an increase in PCO2 leads to a decrease in pH. Conversely, a PCO2 below 35 is alkalotic because there are fewer hydrogen ions. This causes the pH to rise. A normal bicarb, or HCO3, is 23 to 27 milliequivalents per liter. A bicarb value below 23 is called acidotic, and a value above 27 is called alkalotic. This one's easy to remember. It moves in the same direction as the pH. Below normal values means acidosis. Above normal values equals alkalosis. A normal PO2 is 80 to 100 millimeters of mercury. Meanwhile, a normal O2 sat is 96% to 100%. We've discussed acidosis and alkalosis. Now let's broaden that to include all four abnormal acid-base disturbances. These include respiratory acidosis, respiratory alkalosis, metabolic acidosis, and finally, metabolic alkalosis. The respiratory disturbances, as their name indicates, have to do with altered ventilation. In turn, metabolic abnormalities are non-respiratory in nature. Metabolic problems can be caused by poor renal function, diabetes, shock, excessive vomiting or diarrhea, large amounts of nasogastric drainage, or fluid and electrolyte imbalances. When these abnormal states occur, the body tries to compensate, striving for a state of equilibrium. The lungs can begin compensating immediately. However, the kidneys, which are the controlling mechanism for metabolic compensation, are much slower to react. They start compensating
Look, he can't even hold his
24
mouth
hours,
on the...
but may take up to 5 days to reach their maximum potential. Even with these mechanisms in place, the body may not be able to attain equilibrium. Now for the fun part, the family tree of an ABG, or name that baby.
Told you she talks fast.
First, start by writing down these normal values.
I've already done that for you at the top.
pH, 7.35 to to 7.45. PCO2, 35 to 45. HCO3, 23 to 27. These lab values will be used to determine whether your patient is in respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis, or a normal state. As we said earlier, this is called the family tree of an ABG. Each ABG has a first name, a middle name, and a last name. Think of it as you would naming a baby. The first name only has two choices, compensated or uncompensated. The last name also only has two choices, acidosis or alkalosis. The middle name has more choices, so we'll save it for last. The pH always determines the baby's first and last name. In this example, the pH is 7.23. Is this normal? If it is, the baby's first name is compensated. If it's not, the first name is uncompensated. So what is the first name?
So write that down.
Right, uncompensated. Next we'll choose the last name. Is the pH acidosis or alkalosis?
Acidosis. So right in the last name box,
If we
write
said
acidosis.
7.23 is acidotic, you are right. The baby's last name is acidosis. So now we have a first name of uncompensated and a last name of acidosis. How do we determine the middle name? We're going to determine the baby's father. Look at the CO2 value of 32. Is that acidotic, alkalotic, or normal? Refer to the normal values that you wrote down. It's alkalotic, so write down alkalosis beneath the 32.
Beneath the 32.
Next,
Don't
look
write
at
it in
the
your...
HCO3 value of 14. Is it acidotic, alkalotic, or normal? It's acidotic, so write down acidosis underneath the 14. Now you have alkalosis under CO2 and acidosis under HCO3. Refer to the baby's last name. What was it? It was acidosis. The father of the baby will have the same last name as the baby. Where do you find acidosis? Under CO2 or HCO3? Right, under HCO3, which is metabolic. So write in metabolic for the baby's middle name. His name is uncompensated metabolic acidosis. Remember, CO2 represents respiratory and HCO3 represents metabolic. Wasn't that easy? Let's try another. In the next example, the pH is 7.10. Is the baby's first name compensated or uncompensated?
What is it?
You're right, it's uncompensated. Now his last name, is it acidosis or alkalosis?
Acidosis. So write down acidosis.
The pH at 7.10 is acidotic. So baby's first name is uncompensated and his last name is acidosis. Now let's choose his middle name. Go back to the lab values. The CO2 is 63. Is that acidosis or alkalosis? Yes, it's acidosis. So write that under the value of CO2. Next, look at the HCO3, which is 28. Refer back to your normal values. Is that acidosis or alkalosis? It's alkalosis, so write alkalosis under the HCO3 value of 28. Now you have acidosis under CO2 and alkalosis under HCO3. Refer to the baby's last name. What was it? It was acidosis. Who is the baby's father? The father of the baby will have the same last name as the baby. Where do you find acidosis? Under CO2 or HCO3? Right, under CO2, which is respiratory. So write in respiratory for the baby's middle name. His name is uncompensated respiratory acidosis. You're on a roll. Let's do the next one. The pH is 7.51. Is this normal? No, so it's uncompensated. The baby's first name is uncompensated. Now his last name. Is 7.51 acidotic or alkalotic? Yes, it's alkalotic, so baby's last name is alkalosis. Now let's find his father and choose his middle name. The CO2 value is 28. Look at the normal values that you wrote down. Is CO2 acidotic, alkalotic, or normal? Right, it's alkalotic, so write alkalosis under the CO2 value of 28. Next, look at the HCO3, which is 25. Is this acidotic, alkalotic, or normal? It's normal, so write normal under the HCO3 value of 25. Refer back to the baby's last name. What is it? It is alkalosis. Who is the baby's father? Remember, the father of the baby will have the same last name as the baby. Where do you find alkalosis? Under CO2 or HCO3? Right, under CO2, which is respiratory. Fill in respiratory under the baby's middle name. So the baby's full name is uncompensated respiratory alkalosis. Let's keep going. It's fun to name these babies. In this example, the pH is 7.54. Is this normal or not? It's not. So this is uncompensated. Write uncompensated under baby's first name. Is the pH of 7.54 acidotic or alkalotic? Right, it's alkalotic. So write alkalosis for baby's last name. Now let's find his father and choose the baby's middle name. The CO2 is 44. Look at your normal lab values. Is 44 acidotic, alkalotic, or normal? It's normal, so write normal under the CO2 value of 44. Now look at the HCO3. It's 35. Is this acidotic, alkalotic, or normal? It's alkalotic, so write alkalosis under the HCO3 value of 35. Refer back to the baby's last name. It is alkalosis. The father of the baby has the same last name as the baby. Where do you find alkalosis? Under CO2 or HCO3? Right, under HCO3, which is metabolic. So fill in metabolic for the baby's middle name. Therefore, the baby's name is uncompensated metabolic alkalosis. In the next set of values, the pH is 7.36. Is that normal or not? Yes, it's normal, so write compensated for the baby's first name. Now, because this is in the normal range of 7.35 to 7.45, it's not actively either acidosis or alkalosis.
Now pay
However, it is
attention
much
to this.
closer to the acidotic side of normal at 7.36. The body compensates, but it very seldom overcompensates. So because the pH is on the acidotic side at 7.36, the baby's last name is acidosis. Now let's identify the baby's father and choose his middle name. The CO2 is 55. Is this normal, acidotic, or alkalotic? Yes, it's acidotic. So write acidosis beneath the CO2 value of 55. Now look at the HCO3. It's 34. Is this acidosis, alkalosis, or normal? It's alkalotic. So write alkalosis beneath the HCO3 value of 34. Refer back to the baby's last name. Remember that the father of the baby has the same last name as the baby, which is acidosis. Do we have acidosis under CO2 or HCO3? It's under CO2, so the baby's middle name is respiratory. His full name is compensated respiratory acidosis. You see, a compensated condition is interpreted the same way as uncompensated. If the pH is normal, but either the CO2 or HCO3 is abnormal, just look at which side of 7.40 the pH lies. Below 7.40 is the acidotic side, and above 7.40 is the alkalotic side. In the next example, the pH is 7.43. Is this normal? Yes, it is. So the baby's first name is compensated. 7.43 is in the normal range, so determine which end of the range it's on. Is it closer to the acidotic side or the alkalotic side? Right, it's above 7.40 and closer to the alkalotic side. So the baby's last name is alkalosis, unless both CO2 and HCO3 are normal, which we'll discuss in a few moments. So the baby's first name is compensated and the last name is alkalosis. Now let's identify the baby's father and choose the middle name. The CO2 is 30. Is this acidotic, alkalotic, or normal? Correct, it's alkalotic, so write alkalosis beneath the CO2 value of 30. The HCO3 is 20. Is this acidotic, alkalotic, or normal? It's acidotic, so write acidosis beneath the HCO3 value of 20. Refer back to the baby's last name, which is alkalosis. The father of the baby has the same last name. Where do we find alkalosis? Under CO2 or HCO3? Yes, it's under CO2, which is respiratory. The baby's middle name is respiratory, and the baby's full name is compensated respiratory alkalosis. In the next set of values, the pH is 7.41. Is this normal? Yes, so the first name is compensated. 7.41 is normal, but is it closer to the acidotic side or the alkalotic side? It's closer to the alkalotic side, so put alkalosis for the last name.
7.40
Now look
is
at
in
the
the
CO2,
middle.
which is 39. Is this acidotic, alkalotic, or normal? It's normal, so write normal beneath the CO2 value of 39. Next, look at the HCO3, which is 25. Is this acidotic, alkalotic, or normal? Right, this is normal. So write normal beneath the HCO3 value of 25. Now let's identify the baby's father. We have an interesting situation. We called the baby's last name alkalosis because the pH was above 7.40, but still in the normal range. However, both the CO2 and HCO3 are normal. Remember, the same rule applies. The baby and the father must have the same name. If both the CO2 and HCO3 are normal, then the baby must have a last name of normal. Refer back to the pH. It was 7.41, which is within the normal range of 7.35 to 7.45. Instead of a compensated alkalosis, this baby ABG is actually a normal ABG. The key to determining the difference between a compensated ABG and a normal ABG lies in whether either the CO2 or HCO3 are abnormal. If both are normal and the pH is normal, you have a normal ABG. Just remember, the baby's last name must always be the same as the father's. See how far you've come, all these different values, but you can interpret all of them by remembering the basic rules of naming the baby. Now let's try one more that's just a little
You might
different.
have to write this down at the bottom.
The pH is 7.12. Is this normal? No, so the first name is uncompensated. Is 7.12 acidotic or alkalotic? It's acidotic. So the baby's first name is uncompensated and the last name is acidosis. Now let's find his middle name. The CO2 is 58. Is this normal, acidotic, or alkalotic? Right, it's acidotic. Write acidosis below the CO2 value of 58. Now look at the HCO3, which is 16. Is this normal, acidotic, or alkalotic? Correct, it's acidotic also. So write acidosis beneath the HCO3 value of 16. Remember, the baby's last name is always the same as the father's. The baby's last name is acidosis. Now look at the CO2 and HCO3. Which one is named acidosis?
We don't
Both of
know.
them
She was
are.
free with her
Both
favors, so we don't
CO2
know
and
who the
HCO3
father
have the
is.
same name as the baby's last name. That means both of them are the baby's father. So the baby's middle name is respiratory and metabolic. So his full name is uncompensated respiratory and metabolic acidosis. This is referred to as a mixed acid-base disturbance. Now, as you'll recall, we talked earlier about PO2 and O2 sat. These are the other two components that make up the ABG interpretation. Although they are not utilized in determining an acidotic or alkalotic state, they are instrumental in assessing the patient's condition, particularly his or her respiratory status. Now let's tie the ABG analysis to possible causes and treatment modalities. You'll recall that the key factor in determining respiratory acidosis was a high CO2. This high CO2 results from the lungs retaining carbon dioxide rather than blowing it off due to inadequate ventilation. Poor respiratory function results from pneumonia, chronic obstructive pulmonary disease or COPD, and depressed respirations because of anesthesia or high-dose narcotics. Actually, any factor that causes a decrease in rate or depth of respiration below normal can lead to respiratory acidosis. Treatment is aimed at reversing this process. If your patient is sleepy from narcotics or the after effects of anesthesia, you need to closely monitor his respirations. If the respiratory rate is below 12 breaths per minute, try to arouse the patient and encourage him to breathe deeply and more often. If the respirations remain severely depressed, the patient may need to be placed on oxygen or even in extreme cases a ventilator. If respirations are less than 12 breaths per minute, narcotic analgesics should not be given. In extreme cases of acidosis, sodium bicarbonate may be ordered intravenously. The body's own compensation for respiratory acidosis is decreased excretion of bicarbonate by the kidneys. But as mentioned earlier, this process does not begin for 24 hours. If a low PO2 or O2 sat is also present, the patient should be placed on oxygen therapy. The main factor associated with respiratory alkalosis is a CO2 level below normal. Respiratory alkalosis can be caused by hyperventilation resulting from increased anxiety, pain, fever, chills, or sepsis. Treatment is aimed at increasing the amount of CO2 retained by the body. The classic first-line treatment is having the patient breathe into a paper bag. This technique enables them to rebreathe the CO2-enriched air, which was just exhaled. This treatment can be achieved in the hospital by the use of a rebreather mask. Sedation may be required if the patient is extremely anxious to slow the rate and depth of respiration. The body compensates for respiratory alkalosis by allowing the kidneys to excrete more bicarb. But remember, this process does not begin for 24 hours. Metabolic acidosis is associated with a decreased level of HCO3. The most common causes for this include diabetes, shock, and renal failure. Treatment is always aimed at correcting the underlying cause. Nursing actions may include checking the blood sugar and administering insulin as ordered for the diabetic patient. For the patient with renal failure, monitor fluid and electrolytes closely, paying special attention to the potassium, which often is high, and the sodium, which often is low. The body compensates for metabolic acidosis by hyperventilation, which will start almost immediately. Finally, metabolic alkalosis, which is associated with a high HCO3. This condition is caused primarily by volume depletion, hypokalemia, sodium bicarb overdose, corticosteroid therapy, prolonged vomiting, excessive nasogastric tube output, and diuretic therapy. Again, the main treatment would be to correct the underlying cause. Treatment modalities include monitoring fluid and electrolytes, administering IV fluids to correct volume depletion, potassium to correct the hypokalemia, and antiemetics to stop the vomiting as ordered. Be aware that it may also be necessary to alter or discontinue diuretic therapy. The body compensates for metabolic alkalosis by retaining CO2. This is accomplished by decreasing the rate and depth of respiration. You have now mastered the basics of acid-base balance, ABG